Welcome to the Pediatric Nursing Masterclass on Height Measurement, part of our anthropometric assessment series. Anthropometry is the scientific study of human body measurements and proportions. In pediatrics, key indicators include weight, length or height, head circumference, and mid-upper arm circumference. We measure height because it is the best indicator of linear growth and long-term nutritional status, helping detect stunting. Height is also essential for drug dosage calculations based on body surface area and diagnosing conditions like growth hormone deficiency. Here is the golden rule. For children under 2 years, we measure recumbent length using an infantometer. For children over 2 years, we measure vertical height using a stadiometer. Recumbent length is greater than standing height by approximately 0.7 centimeters. This difference occurs because, when standing, gravity compresses the intervertebral discs and flattens the arch of the foot. The infantometer is used for children under 2 years of age in a supine position. It features a fixed headboard, a movable footboard, and a scale accurate to 0.1 centimeters. Measuring length requires 2 people. The assistant holds the head against the fixed board. The measurer straightens the knees and brings the movable footboard against the heels, then reads the measurement. Common errors include performing the measurement alone, not removing thick diapers, bent knees, and parallax error when reading the scale. The age cutoff for switching from length to height measurement is 2 years. The movable part of the infantometer is the footboard. The stadiometer is used for children over 2 years and adults in a standing position. It consists of a vertical ruler mounted on a wall and a horizontal sliding headpiece. To measure height, ensure the child removes shoes and hair ornaments. They should stand with their back against the wall, maintaining 5 points of contact: the back of the head, shoulders, buttocks, calves, and heels. Head positioning is crucial. The Frankfurt plane, a line from the eye orbit's lower margin to the auditory meatus's upper margin, must be parallel to the ground. The Frankfurt plane ensures the head is level for accurate measurement. 5 points of the body should touch the wall during height measurement. The Frankfurt plane ensures the head is level. The average birth length is 50 centimeters, ranging from 45 to 55 centimeters. Preterm infants will typically have a significantly lower length. During the first year, there is a total increase in length of about 25 centimeters, representing a 50% increase from birth. In the second year, length increases by about 12 centimeters. The total length at 4 years is approximately 100 centimeters. From preschool to puberty, the increase is about 5 to 6 centimeters per year. Key height multipliers to remember. Birth length is 50 centimeters. It doubles around 4 to 4.5 years, reaching 100 centimeters. It triples around 13 years, reaching 150 centimeters. Weech's formula can estimate height for ages 2 to 12 years. Height in centimeters equals age in years times 6 plus 77. Birth length of a child typically doubles at 4 to 4.5 years of age. The approximate length of a healthy infant at 1 year of age is 75 centimeters. Adolescent growth spurts differ between genders. Girls start earlier and stop growing sooner. Boys start later, have a higher peak height velocity, and grow for a longer period, resulting in taller final height. Growth charts use WHO standards for children under 5 years. Plotting measurements over time reveals the growth curve. A danger sign is the flattening of the curve or crossing percentiles downwards. Stunting is indicated by a z-score of less than -2 standard deviations, signifying chronic malnutrition. Short stature is defined as height below the 3rd percentile. Common causes include familial short stature, malnutrition, hypothyroidism, and growth hormone deficiency. Tall stature is height above the 97th percentile. Causes include gigantism, which is excess growth hormone before bone fusion, and Marfan syndrome, a connective tissue disorder. The upper segment to lower segment, or US to LS, ratio compares the length from the top of the head to the pubic symphysis with the length from the pubic symphysis to the heel. Checking the US to LS ratio helps differentiate between types of short stature. Proportionate dwarfism has a normal ratio. Disproportionate dwarfism, like achondroplasia, has an abnormal high US to LS ratio. Arm span measurement is the distance between the middle fingertips when arms are outstretched. In Marfan syndrome, the arm span is greater than the height by more than 5 centimeters. The upper segment to lower segment ratio becomes 1 to 1 at around 10 years of age. Adult height can be predicted using the mid-parental height formula. The calculation for boys adds 13 to the combined parental heights, and the calculation for girls subtracts 13. Both results are then divided by 2. The US to LS ratio at birth is 1.7 to 1. Marfan syndrome is the condition where the arm span is much greater than the height. The instrument used to measure height in children older than 2 years is the stadiometer. Accuracy in measurement is affected by parallax error, incorrect positioning, equipment issues, and diurnal variation, as height decreases slightly in the evening. Key micronutrients for height include zinc, calcium, vitamin D, and protein. Stunting indicates chronic malnutrition and is usually irreversible after 2 years of age. This rapid revision sheet summarizes the key information presented in this video. Height is a critical indicator of long-term health. Always distinguish between length for children under 2 and height for those over 2. Ensure correct positioning and monitor for stunting. Thank you for watching this video. Keep learning and keep growing.